Hey, my name is Justin Kreuter, the Bowtie Bandit of Blood, and I'm giving you this lecture right now about transfusion medicine decisions. I'm using this slide set of how does coagulation really work because my story, my origin story for talking about transfusion decisions is I trained at a hospital where we were expected as pathology residents to be bedside for any major bleed on our patients. And at first, I felt kind of like a random number generator, giving a couple units of red cells, maybe some plasma, and then thinking, well, I haven't given a platelet in a little while. I really was. Really at the most basic level, I think I was approaching my bleeding patient by trying to kind of make sure I have a little bit of everything in the mix, and then looking at the lab values to make sure that my platelets were sufficient, my plasma looked like I had been aggressive enough. Um, and I quickly came to appreciate, though, a hematologist took me under her wing and taught me the dark arts of coagulation so that I would understand how to make better decisions about my bleeding patients and when certain blood products or factor concentrates can really make a difference for my patient. And so once I learned how coagulation really worked inside the body, then when I was approaching bleeding patients, I was able to analyze the situation by thinking about, what am I seeing for the type of bleeding and the location of bleeding? What do I know about the patient's underlying disease process? And then also, what are the lab tests telling me with an asterisk for being cognizant, being aware of what are those limitations of those coagulation tests? So that's the background. Once I understood that, I now approach these bleeding patients and can see a rationale for why are they bleeding and coming up and can develop a plan for hemostasis. So for this particular talk, there's no relevant disclosures. There's quick mention of additional tools for hemostasis at the end. So that's when I'm talking about factor concentrates that will be off label. But as far as paychecks, Mayo Clinic pays my salary. So our learning objectives right now is to first recognize the different components of in vivo coagulation. After we understand that, then we want to understand, okay, how does this process actually work inside the body? And then third, we want to come back at the end and kind of, put a cap on it and make sure we understand what are the clinically significant aspects of this coagulation. So I think here's our classical coagulation cascade that I think a lot of people learn it by um, maybe just for an exam, and they probably learn some jingle that helps them regurgitate these numbers in sequence. And when I'm teaching this in person, I put this on the board because I don't think it's as important, but I think what's important that we'll talk about today in this lecture is the story of this coagulation cascade, because I think that's where we really get what's the meaning for this. I think when the novice looks at this, it just looks like a series of numbers, and what the meaning of that is really lost. And I hope at the end of this lecture you really have a meaning understanding for what these numbers represent and what this process actually is. It is true that this coagulation cascade is representative of in vitro hemostasis inside the test tube, and highlighting that this talk is going to be about how it actually works inside the body. I think it's still important that we are aware of the classical cascade because a lot of times we're using the testing that we're doing to inform our decisions for patients. So understanding in vivo and in vitro each has their merits. So, okay, what are the different components of in vivo coagulation? This is my older daughter. When she was quite a bit younger, we were at the grocery store and she was just looking at all these different kinds of candy. And sometimes I think people can feel like that when they think about coagulation. It's almost, just like my daughter seems to be overwhelmed with what are the choices for candy for her. I think sometimes people, when they think about coagulation, it is so huge that it just becomes something like, I guess we have procoagulants, we have anticoagulants, maybe somebody will pick out we have platelets. But again, the core thing that I want to hit on is what are the meaning for these different components. So let's dive in here. What are the principles of coagulation? So if we can imagine here a vessel wall, endothelium is marked by these kind of blue rectangles, and that kind of hole in the middle at the bottom of the screen as a break in the blood vessels. So tissue defect, stab wound, whatever you want to do, but kind of imagine that the top of the slide is inside the vascular space, and there's this hole at the bottom in the center, and the blood's going to flow out that way. So the first principle of coagulation is, well, we need coagulation to be sufficient so that we actually cover the tissue defect, cover the hole. Um, if we have a coagulation system that only partially covers the hole, well, that doesn't exactly cut it, does it? So that's the first principle, is that it has to be sufficient. The second principle is it has to be measured, right? So we can't have coagulation that is, over and above and excessive, right? So in other words, if I have an injury, yes, I need hemostasis and I need sufficient hemostasis, but if it's a minor injury, I really don't want to turn my body into one big clot, right? Because that way blood's not going to flow to my vital organs. So I want the coagulation response to be measured so that it's appropriate. And then the third is that it's localized, right? So in other words, if I get a stab wound, I certainly want hemostasis where I've been stabbed. To have my hemostatic system working in some other place in my body as a result of being stabbed isn't doing me any favors. And so those are the three I like to kind of point out as the principles of coagulation. And I think that we want to keep this in mind. So put a pin in these three in your minds, that we need hemostasis that is sufficient. We need hemostasis that is measured. We need hemostasis that is localized. So these principles are the foundation for the process that we're going to talk about. So when we're talking about these processes, there are actually these four processes of coagulation. So for those of you that like to break things down, this is kind of platelet function, which is classically described as primary hemostasis. Then you've got fibrin formation, or sometimes people call it plasmacytic coagulation, or sometimes we learn this as secondary hemostasis. Then we also have the endogenous anticoagulants. Again, keeping in mind that Now we're talking about how are we getting a measured response. So platelet function, fibrin formation, those first two are how we are dictating a sufficient response. Then three, endogenous anticoagulants are making sure that we have a measured response. And the fibrinolytic system is helping to make sure not only with tissue healing, but it also makes sure that the coagulation response stays localized. So, because coagulation is a complex topic, and we're going to take this and hopefully build on it through your rotation during our conversation today, we're really going to focus on those first two. So, primary hemostasis with platelet function, and secondary hemostasis with fibrin formation. So, okay, this is again my oldest daughter when she was quite a bit younger, when I was teaching her how to pick a lock, and I love her focused face as she's learning how to pick a lock. And I'm a proud papa looking at her very, delicate hold on her tension there. And so, similarly, as we go through talking about coagulation, which is a classically difficult topic, I'm really asking you to have the same sort of focus that my, at the time, 3-year-old had at learning to pick a lock. Put a little bit of focus into this next series of slides, because this is really the story of hemostasis, a very classically challenging topic for most of us. But I think it's really important for understanding our patients. So again, this model of the blue endothelium, most of the slide, the top of the slide is within the blood vessel. There's this hole in the middle, and this arrow is showing you the direction of blood flow out the hole. And obviously, we don't want blood flowing out that hole, so we need hemostasis. So what happens first in hemostasis? Um, what happens first? So a lot of times people talk about, well, platelets come about and you get primary hemostasis, you get the platelet plug. And yeah, but platelets don't just come there by themselves and, hit the brakes and form a barrier across this hole. What happens in this process? Well, first, the platelet has to get caught on something, right? So the platelet is flowing out this hole, and if nothing catches it, the platelet's going to fall onto the floor and be on somebody's shoes, maybe. And so what catches that platelet is von Willebrand factor. And this is what I've got kind of represented by this image of some solder wire that I had, because von Willebrand factor is this kind of springy, flexible, kind of zigzag substance. And it is reaching out from damaged endothelium into these spaces of blood flow. And when a platelet comes by, a platelet can get caught. And so you see the kind of happy platelet in the top left of the slide, because it's just going along through the bloodstream, dum-de-dum. But then once the platelet gets caught with von Willebrand factor, and one thing I want to highlight here is it gets caught so effectively by von Willebrand factor because von Willebrand factor is stretchy and binds with high affinity to platelets. So sometimes people talk about platelets binding to collagen, and while that's true, in the initial stages when blood flow is very fast through these holes, the collagen isn't as stretchy as von Willebrand factor, and so the collagen can't really get a good grip on the platelets. But because the von Willebrand factor has this kind of zigzag flexible structure, it almost acts like an arrest wire on an aircraft carrier, that wire that catches the airplanes as they're coming down at a high rate of speed to land on the deck of an aircraft carrier. And so it grabs onto the platelet and slows it down the same way those arrest wires grabs onto the plane and slows it down very rapidly. And when a platelet binds to von Willebrand factor, that's what activates the platelet. So that's why you see it kind of flipped over, and an activated platelet, it doesn't have that nice, simple, discoid kind of shape. It starts getting all these kind of protrusions out to kind of bind to and increase its surface area, because it's trying to make that platelet plug, that primary hemostasis. What's particularly cool is that platelets that are activated, or I don't know, cool is not the right word, I guess what makes things really effective is that activated platelets send out signals to tell other platelets in the area that this is an area where they need to become activated and participate in making that primary hemostasis, that platelet plug. And so what happens is these activated platelets spew out a couple things that I just want to highlight. So they're kicking out thromboxanes, which, pharmacologically we can inhibit through drugs like aspirin. They're also kicking out ADP, and ADP, we can suppress ADP receptors on platelets by giving people Plavix, antiplatelet drug. And then Mother Nature has created redundancy, and so she has given us another thing that is very potent to activate platelets, and that is thrombin. So that's something to keep in mind here, is that thrombin, which is activated factor 2, so factor 2 is prothrombin, activated factor 2 is thrombin. That automatically is something that, or it's not automatically, it's something that I want to point out is a connection between primary hemostasis and secondary hemostasis. So secondary hemostasis, we generate thrombin. Primary hemostasis, thrombin can activate platelets. So even though we're learning hemostasis as these kind of segregated areas of primary and secondary, that truly is artificial. These are occurring simultaneously and together. And so what I want to highlight here is Mother Nature, by giving us this redundancy of multiple chemicals that are in this area from an activated platelet, that other platelets that are in the area can pick up on this signal, and we have this biological redundancy. And so I sometimes describe it as, if you're going out clubbing with your friends, you might, how do you know that you're in the area of the club or you're getting close? And, maybe you can smell the cheap cologne. Maybe you can hear the techno music. Maybe you can see the glow sticks being spun around, right? So those are different signals that you're getting, that that you're getting into an area that, oh, the club's right around the corner, or right up here. Same thing with the platelets. So this quiescent platelet that's coming here from the top left, it can receive these signals from this activated platelet so that it gets ready and it's prepared for this area where we need to have hemostasis, instead of just slipping through the hole. Because remember, at this stage of hemostasis is a very early, there's a whole lot of open space for coagulation factors to slip through and spill out on the ground. This isn't a platelet plug at this point. This is just like a colander that you use to sift through water when you're making pasta. So again, this activated platelet can activate other platelets through a biological redundancy. And so why that's clinically important is to understand how our antiplatelet medications work, and also why um, somebody can be on dual antiplatelet therapy, yet uh, is still able to make a competent thrombosis or hemostatic response. Um, so now that we got activated platelets, we can now understand that the platelets are binding along this von Willebrand factor. And so the fancy pants name for this is adhesion. So the platelets are adhesing to the von Willebrand factor. But in order to make a plug, we need aggregation. So adhesion happens first, and then aggregation happens second. And that means that you want platelets bulking up. Now, before we dive into this, because you might say, yes, 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 this is it. We're making the primary platelet plug. I'll ask you, how are platelets binding to one another? How are they connecting? It stumps a lot of people usually. So platelets actually are connecting to each other via fibrin. So fibrin is what is the connector binding platelet to platelet. Without that, it's kind of like having two electrical sockets. There's nothing to hold them together. You need a spacer that can bind to the two of them, and that's what fibrin does. And so this also highlights the fact that in real life, it's not primary hemostasis first, it's called primary, and then secondary hemostasis second. The two have to be occurring simultaneously, because right now I've demonstrated for you that it's impossible to form a platelet plug without an adequate secondary hemostasis, plasmacytic hemostasis function. So let's hit pause and let's go back to say, how do we get the secondary hemostasis activated here? And well, that is through factor 7. So for those of you that have that classic coagulation cascade out in front of you, that might seem like the very obvious step. And one thing I want to point out is that factor 7, in order for it to get activated, what starts off that part of the cascade is something called tissue factor, which you might think of as, geez, the most beautiful unicorn in that, for me and you, we don't have tissue factor really abundantly floating through our bloodstream right now. But if I were to get stabbed, I would have a lot of tissue factor at the site that I got stabbed. And that's kind of magical, cool. And also pointing out that that's one way that our coagulation system maintains a localized response. And so, what tissue factor is really is just bust up cell membrane. So you can see, if you were Mother Nature designing a coagulation system, how perfect is that for making sure that coagulation stays localized. So in other words, whether I'm stabbed, that's the knife going through this blood vessel and shearing up those endothelial cells. Those fragments of endothelial cells are tissue factor, which is going to bind to factor 7 in my bloodstream and start activating the extrinsic coagulation cascade. Or in vivo hemostasis, we talk about this as the initiation or the starter motor of coagulation. So that's really cool and fundamental to understand, is that tissue factor, how is it keeping things local? Okay, great. So now we have factor 7 activated because tissue factors bound to it. And sometimes if I have this in real life, if we're sitting down doing this lecture, we might have paper representing endothelium on the tabletop, and I'll kind of tear off little shards of that paper to represent the endothelium that got damaged and put some paper on top of this factor 7. Now that 7's activated, the next question is, well, what happens next? And you might start talking about activating other coagulation cascades or other coagulation factors. But I guess I'd challenge you and say, well, why doesn't activated factor 7 just spill out onto the floor? Because remember, we have a hole at this point, and we've got a lot of blood flow going out. Why doesn't factor 7 just go with the flow and fall out of the body? Well, it doesn't do that because of this star. So the star in this graphic is indicating really two things. So the first thing that it's indicating is gamma carboxylation. And you might say, why do I care about gamma carboxylation? And well, you care about it because that's the step that is inhibited by vitamin K dependent factors. So when we give somebody warfarin Coumadin as a medication, that interrupts their vitamin K dependent pathway, and the liver is unable to do that post-translation modification of adding a gamma carboxyl group onto certain coagulation factors. And factor 7 is one of those factors. But again, going back to why do you care about it? So great, I understand there's a pharmacologic target for it in warfarin Coumadin. Well, also you care about it because that's what allows certain coagulation factors to bind onto activated phospholipid surfaces. So that's platelets, that's endothelial cells in the vicinity. Importantly, it's not healthy endothelial cells, because healthy endothelial cells has that glycocalyx kind of snot-like layer on top of it. So there's not that ability for these coagulation factors to bind onto it. And so that's another way that our coagulation system is keeping things localized. And so that's why we care about gamma carboxylation, is because that allows coagulation factors to bind onto these surfaces and not get washed out with the blood flow. Now, the other thing, I said the purple star here represents two things. The first is gamma carboxylation, and the second is ionized calcium. So in other words, we need ionized calcium as a cofactor for that gamma carboxyl group to work. So in other words, and I guess I'm harping on this, and I'm harping on it for a good clinical significant reason, is because our patients that are massively bleeding, ionized calcium is really important to monitor, right? Because if your ionized calcium drops low, your coagulation factors cannot bind onto these phospholipid surfaces, and so they just get washed out with the blood flow. I submit to you that a patient who is hypocalcemic or has low ionized calcium, they have the same coagulation process as somebody that's like toxic on Coumadin, because these coagulation factors cannot bind onto these phospholipid surfaces. So that's important to realize. I think the next question might be, well, how important, like, I understand it's important for coagulation, but why is it such something that we need to be watching? Um, and in, and the reason for that is because all of our blood products have citrate in them to stay liquid, right? If we didn't have citrate in those blood bags, then the blood that was in them uh, would firm up like jello, and that doesn't really make a transfusible blood product. And so all of our blood products have citrate. And so when you're doing your routine outpatient transfusions, 1 unit of a certain blood product, like that's very little citrate. Um, Most of us have livers that work, and so the liver just very efficiently turns that citrate into carbon dioxide. We breathe it out. But for the patients getting massively transfused, that citrate is going to be chelating that ionized calcium, and so possibly contributing to problems with hemostasis. So when we transfuse patients, a lot of times, or when patients are bleeding, a lot of times people are concerned about dilutional coagulopathy contributing to coagulopathy. So you don't have you're not being aggressive enough with the blood products. I guess what I want to make sure is on your radar is if you are being aggressive with blood products, and certainly we should be in the bleeding patient, uh, that we need to be watching what that ionized calcium is and replacing it. Number one, probably for heart function, because if our ionized calcium drops too low, the heart doesn't work too well, and patients certainly die of cardiac arrhythmias. But also because the coagulation system needs it for normal function. Okay, maybe at this point I might be beating a dead horse. So let's go on now. So what does factor seven do? What Now that we understand seven's activated, we understand that seven is bound into this space and not just going to fly out of the hole in the vessel. What happens next? And I think a lot of people talk about activating factor 10 because they're looking at that coagulation cascade. And while that's true, activated 7 can bind to 10 and activate it. That's not what happens in vivo. That's not the story of hemostasis. And so what happens is factor 7 actually goes over and is going to activate and start up the first of two complexes. So that coagulation cascade is actually representing two complexes that get made. They are the tenase complex, and then the second one's called the prothrombinase complex. Let's take this in turn. So the tenase complex is formed of factors 9, 8, and 10. And so let's take a look. So what happens is 7 is going to activate factor 9. And remember, factor 9 is a gamma carboxylated. It's a vitamin K dependent gamma carboxylated coagulation factor. So it's going to bind onto this phospholipid surface with the help of ionized calcium. We also have factor 10, which also is a vitamin K dependent factor binding onto this platelet surface. And so I just want to hit pause here to call attention to the brilliance of the coagulation system here, right? So we're trying to make a complex. Remember, these are enzymes, so they need to kind of come together in that kind of lock and key formation, right? And so, in other words, what's the chances that factor 9 and 10 are going to come together, lock and key perfectly when they're spinning in 3D space, right? Probably slim, very slim, unless there's stasis going on. Hence, one of the causes of thrombotic issues. But otherwise, the chances of them coming together lock and key are very slim. And so, what Mother Nature has done is she has anchored So she is put in, this is where I kind of usually kind of knock both my elbows on a table and say, okay, instead of spinning out in 3D space, 9 and 10 are anchored onto the same surface. And so what that means is that the anchoring on the same surface means that we're not contending with 3D space anymore. We're just contending with two-dimensional space because we're on the same surface. And so what brings them together, lock and key, is factor 8, playing the role of matchmaker. And you might say, okay, come on, do I really need a matchmaker? Well, if you don't have factor 8, you have hemophilia A. And so, yes, it turns out even though you're bound onto this same phospholipid surface, you do need a matchmaker. You do need factor 8 to bring 9 and 10 together in the first of two complexes important in coagulation. This complex, again, is called the 10A's complex. And it's kind of an appropriate naming, right? Because it's activating factor 10 is the whole purpose for this. And it's an enzyme, so that's where you get the 10A's complex. Okay. I made such a big deal about 9 and 10 being bound onto the surface, but notice that 8 is not a vitamin K dependent factor. It does not have the gamma carboxyl group on it. It does not bind onto the surface. And I made such a big deal about things not bound onto surfaces flying out the hole. What the heck's the deal with this factor 8? Well, where's 8 coming from in this area that makes it so abundant it's not as critical? And the answer is that's where factor 8 normally is piggybacking on von Willebrand factor, right? That arm that's reaching out and grabbing onto platelets. And so when that arm gets splayed out because it's grabbed onto platelets, that pushes off all this factor 8 in the area. It's kind of like a glitter bomb going off. I've got 2 young daughters. There's good chance there's glitter stuck on me somewhere. And that's what's going on. That's why 8 is around so abundantly in this area, that we're not so concerned that it doesn't bind to a phospholipid surface. Okay, so that's the first complex. And now we're going to go on to the second complex. And the second complex, the nice thing about Mother Nature is when she finds a solution, she hits copy and paste. And so it's a similar setup. This one is called the prothrombinase complex. So we've got factor 10 that's activated, bound onto the platelet surface. And again, I'm clearing away these other cards that we've talked about, not because they're going away in real life, but just for cognitive load, that it's not so complex as we're learning it, me and you together here. So factor 10 is bound on this phospholipid surface because the gamma carboxyl group in ionized vitamin K. We have prothrombin, which is my Clark Kent here. So that's factor 2 is also bound. It's a vitamin K dependent factor, so it's bound onto the phospholipid surface. It's got ionized calcium that's enabling that to happen. And then in this complex, the matchmaker is factor 5. And it's the exact same reason, rationale. And then why is factor 5 around so abundantly? What's the source of the factor 5 glitter bomb that we have going on? Well, it turns out that factor 5 is one of the coagulation factors that's released from activated platelets. So platelets that are getting activated are pushing out a lot of factor 5 into this localized area. And so that's what we're seeing. So this come together, remember, this is called the prothrombinase complex. And so that means that that prothrombin that Clark Kent gets activated into thrombin. Remember, we talked about thrombin as also activating other platelets in the area. Thrombin also is going to feed back on this coagulation system. Now that we've done initiation of coagulation from factor 7, activating these two complexes, now our thrombin is going to feed forward and activate these complexes through factor 11. And if you look at your sheet of the classical coagulation cascade, right, you might look over and see that intrinsic cascade, and you might say, now, thrombin activates at multiple factors. That's a lot to learn. I just focused on factor 11 because if you don't have factor 8, you have hemophilia A. If you don't have factor 9, you have hemophilia B. If you don't have factor 11, you have hemophilia C. If you don't have factor 12, you don't care. Factor 12 is critical for the test for in vitro hemostasis, the PTT test, the ACT, activated clotting time test, but it doesn't matter inside the body. And that's because I like to think of it as thrombin activating factor 11. And now we're no longer dealing with the starter motor of coagulation. Now it's actually the engine running, and factor 11 is what's going to activate the 10A's complex. Notice that now that the engine's running, nobody cares about factor 7. 7 is only important for initiation of coagulation. It is the starter motor. Our body actually intentionally shuts down that starter motor after this pathway is kicked over into what we're seeing now as amplification, so that we can preserve our starter motor. It's the same principle as your starter motor in your car. You could keep your starter motor going while you drove, but you would quickly burn out your starter motor and you wouldn't be able to get your car started again. So same thing with coagulation. If I get stabbed, I want my starter motor of coagulation to get things going, but then I'm going to shut it down so that I can be ready in case I'm stabbed a second time. My starter motor can work again. And so I just point that out because a lot of us in clinical practice are focused on that starter motor when we look at things like INR, right? The factor 7 level is the strongest determinant of what our patient's INR is. So, okay, going back to what we see here, we're seeing now amplification. So now it's 11 activating the 10A's complex, which is then going forward and activating the prothrombinase complex. So look at this now. What you see in front of you on the screen here, this is in vivo hemostasis. And hopefully through our conversation here, you've come to appreciate the story of coagulation. Because really what this is now is the whole coagulation cascade's reason for being is to generate thrombin, to generate this Superman of the coagulation system. Because as it turns out, thrombin is the only thing inside of our bodies, unless we get bit by certain poisonous snakes, that is able to cleave fibrinogen into fibrin. Remember, fibrinogen is not activated. It is water soluble and it floats around in our bloodstream. When we have thrombin that cleaves it, it becomes activated. It becomes fibrin. It becomes water insoluble, and it precipitates out. And what did we talk about in the beginning? platelets are bound to one another because of fibrin. You get a lot of fibrin around, then you get a lot of fibrin around, and then you can have a lot of platelets bound to one another, and that is how we get a platelet plug. So notice that we needed primary and secondary hemostasis for a platelet plug. So when we get into bleeding patients, just because you're not getting that initial hemostasis, that doesn't mean that the focus is we need more platelets, we need more platelets, we need more platelets. If the coagulation system isn't working, those platelets can't aggregate. Those platelets can't bind to one another. So we need this whole process to be working for that simple thing to happen. Okay, let's go on to the last phase here of this presentation talk and just hit on, okay, what are these clinically significant aspects of hemostasis we're talking about here, right? Because, it's like, hey, you're looking at playing cards and poker chips, but this is really serious stuff that we're talking about here. This is my fantastic drawing of the classical coagulation cascade. And I think what I want to point out here is that this is a process. This is a process that has a couple of participants. Somebody might come back and criticize and say this is a complex process. This is too complex. But I guess I would push back and say that it's as complex as it needs to be. Because remember, if we just had something that was like an on and off switch, right? Like if we just had thrombin, like injury activated thrombin, well, I might bonk my hand in a door jamb today, and I don't want my hand to clot off because that stinks. I need a measured hemostatic response, going back to our fundamentals, right? So if I need a measured response, I can't have a simple on-off switch. I need a dimmer switch, right? So instead of a light switch, Mother Nature, with these two complexes, has given us a dimmer switch so that we can operate with these principles of sufficient coagulation. So if I have a larger injury, there is a more stimulation for more coagulation factors, so I have a sufficient coagulation response. But I also have enough factors to where I can have inhibition working so that I can also have a measured response, and so I don't overdo it. So these are important to appreciate. So although there's seemingly a lot of complexity, at the end of the day, it's just two complexes that Mother Nature has given us, and two complexes is complexity enough that we can have overall, we can get a sufficient hemostatic response, but also a measured hemostatic response. And then I think I showed you throughout the presentation so far how localization is, quote unquote, baked into this process. Okay, what else? What else is important to appreciate out of here? Well, another thing to appreciate from what we've talked about is kind of this physicality of these things occurring, right? So we appreciate that all these players are necessary to make this thing work in general. But this thing that we're talking about working, this is an enzymatic process, right? So what that means is that this is both pH and temperature dependent. It's pH and temperature dependent. So what that means is, I guess, going back for some of you that may work in the trauma world, when we talk about what is the triad of death, people will recite and say, well, it's coagulopathy, acidosis, and hypothermia, right? And so let's just talk about that for a second. A lot of times when they're saying coagulopathy, they're thinking dilutional coagulopathy, so not enough clotting factors. But what I want to point out here is, well, acidosis, if our patient is acidotic, right, low pH, these enzymes, because the coagulation cascade is an enzymatic cascade, they don't work. You might as well have water in your veins, right? So similarly, if you're in Minnesota in the winter and you're outside on Highway 52 in an accident, you get cold. And so temperature also makes your coagulation system not work. People that are quite cold in their core temperature don't have a functioning coagulation system. So they all lend into coagulopathy. So my very coagulation-centric view of life, but it's true. And so what does that mean in practice is it puts importance on some of these fundamentals, things like warming the patient, keeping the door closed to the trauma bay, making sure that we get the bear hugger on the patient as soon as possible. These are why these things are important. When a patient has a bleed, it's important that we hold pressure on that bleed so that we minimize the amount of loss of these coagulation factors. So we minimize the amount of loss of the patient's blood volume, because as we lose blood volume, that's what's not allowing oxygen to get to tissues, which is what causes lactic acid to build up, which is what causes our coagulation cascade to not function. So these basic principles of when patients are injured, that we need to hold pressure, we need to minimize blood loss, we need to keep the patient warm, we need to monitor pH, we need to monitor their core body temperature. These fundamentals, this is why this is important. And then lastly, like I've said, I think a couple of times through this presentation, we need to monitor the ionized calcium in our massively transfused patient to make sure that they still have a coagulation system. So those are a couple of the fundamentals that hopefully, after now that we've kind of talked through this process or the story of coagulation, it makes a lot more sense. Makes a lot more sense. So that's, I guess, the benefit of a recording, is if it doesn't make much sense, please take some time to watch it again, or watch parts of it that didn't make sense to you, or reach out and ask me questions. So hopefully this kind of highlights, when we think about component therapy, how do we think about these things, right? So, I guess starting from the left about red blood cells, you might say, well, geez, it doesn't seem like red cells are that important, right? Because so far when we talked about coagulation, it's a lot more focused on the yellow stuff. But what I want to caution you against is that, we can tolerate severe shortages of the yellow stuff in patients for periods of time. The body is not so tolerant if it lacks oxygen carrying capacity, right? So when we have our bleeding patient, a lot of times our focus is on yellow products. What I want to make sure you understand is that we need to maintain that oxygen carrying capacity. We need to maintain the patient's red cell mass. Other blood products, so the next one to the right is a platelet unit. We need those platelets to be available to help to make those platelet plugs. Next to the right is fresh frozen plasma, so it has all coagulation factors in it. So in our bleeding patients, we don't know why they're bleeding. Generally, it's good to keep all of these coagulation factors going into the patient. That's why we're using FFP. And then we've got cryo on the far right, which is a smaller blood product. But what I want to highlight is cryo is not FFP for little people or people that can't take the volume of FFP. Cryo is manufactured from FFP. It does not have all the coagulation factors. In fact, it only has fibrinogen, factor 13, factor 8, and von Willebrand factor. These are very important factors when it comes to hemostasis, which is why it's a product we should be using in our bleeding patients, but it's also why it's not the only product that we're using in our patients. We also have some additional tools, that we use to help support this process. Some of these might be off-label, so depending on their usage and how we're using them. But hopefully the story of coagulation has now made these additional tools make sense. So as you think about and reflect on this lecture, you might want to take a snapshot of this image, is reflect on, when would I use antifibrinolytics? When would I use prothrombin complex concentrates? When would I use coagulation factor 7A? When would I use fibrinogen concentrate? And so on and so forth. And that's my challenge to you with this lecture, is to reflect on that and try to answer those questions. And please reach out with your questions. So how does coagulation really work? I want you guys to recognize the components of in vivo coagulation. We talked through the process or the story of in vivo coagulation. And at the end there, I think we hopefully capped some of those key aspects for hemostasis and coagulation. So thank you all so much.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.